Hello, this is Vinnie Seiverling, and I will be taking you through a series of pediatric dermoscopy cases today. This webcast is brought to you by the International Dermoscopy Society and Anthelios La Roche-Posay. Today we will focus on the use of dermoscopy in the pediatric population. There's an abundance of literature on dermoscopy and its role in skin cancer detection in adults. This image is from a recent publication that I was part of, summarizing the most high-yield topics for dermatologists and in-training dermatologists. But if you look closely at this list of diagnoses, you will see that many of them are not common occurrences in young children. For instance, skin cancers and basal cell carcinoma, as well as melanoma, very, very rarely occur in young children, as do seborrheic keratoses. While abundantly common in adults, they are very rare in children. And yet, children do experience a large number of non-malignant growths at a young age. Up to 10% of infants will have a congenital melanocytic nevus or a vascular growth like an infantile hemangioma. And at times, it can be difficult to categorize these growths as vascular, melanocytic, keratinocytic, sebaceous, because children have immature adnexal structures. Through the use of dermoscopy and that in vivo 10x magnification, we can appropriately categorize growths, and we can help make those important decisions as to whether something really needs to be removed in the pediatric population. This can be challenging because biopsies sometimes require general anesthesia, or if based on what we're seeing under dermoscopy, something might be safe to monitor. The other thing to keep in mind is that children in general are not afraid of our fancy flashlights. Most of the time, children are very amenable to evaluation of their skin growth using non-invasive tools like dermoscopy. So to kick things off, I want to demonstrate how dermoscopy helps us with the evaluation of congenital melanocytic nevi. Up to 6% of the population will have a congenital melanocytic nevus, and the most common patterns under dermoscopy are a globular pattern or a reticular pattern, sometimes on a homogeneous brown base. When you look at the distribution of congenital melanocytic nevi, the globular pattern has a predilection for areas on the head and neck, like we see here. Large melanocytic nests are often described under dermoscopy as a cobblestone pattern. Here, we can see that the melanocytic nests that we see under dermoscopy correspond with brown circular structures. If they're quite small, we call them dots. If they are medium-sized, the term is globular pattern or globules. And if they're larger, as we often see in congenital melanocytic nevi, we often use the term cobblestone pattern. This is a congenital melanocytic nevus on the neck of a 17-year-old, and what we can appreciate is a uniform distribution of the brown circular globules, all of which represent nests of melanocytes at the dermoepidermal junction. The term organized pattern is used because there's a distribution that is reassuring to the eye of these globules all throughout. The ABCDEs of melanoma do not apply to dermoscopic images, and therefore we can accept when we see a small amount of border irregularity under dermoscopy that this is not a worrisome finding, because many congenital melanocytic nevi will have slightly irregular borders and yet an organized distribution of their globules and have a reassuring appearance under dermoscopy. The globular pattern is one of the commonly described melanocytic nevus patterns with a reassuring distribution of either globules or network under dermoscopy. Another example of a congenital melanocytic nevus with that distribution of cobblestone globules all throughout and hypertrichosis. Sometimes the globules are distributed in small aggregates off the edge of the primary nevus. This is a congenital melanocytic nevus on the temple with a significant amount of hypertrichosis, and off the edge we can see all of these nests of melanocytes in little aggregates. Sometimes with time, these scalp congenital nevi and aggregates of melanocytes in the globular pattern will fade and not be as noticeable as the child gets older. Another congenital melanocytic nevus on the eyelid of a 9-year-old. Here we see that nice bed of brown, that homogeneity, light brown, on which the dots and globules are overlying, with an additional component of hypertrichosis. As this child got older, 1 year later, it got slightly larger, but really no worrisome features. 1 year later, we saw that light bed of brown, uniform distribution of dots and globules, and hypertrichosis. In summary, most of the congenital melanocytic nevi with a globular pattern will be located on the head and neck or in a midline area. This pattern is very reassuring and usually has a distribution of globules all throughout, described, as we said, as a cobblestone pattern. One thing to keep in mind is that congenital melanocytic nevi in the globular pattern differ from Spitz nevi in that in the globular pattern seen in congenital melanocytic nevi and in acquired melanocytic nevi, there are often detached globules, as indicated by the blue arrows in the image on the left and in the center. This contrasts with what's called the starburst pattern seen in pigmented Spitz neoplasms, where there are pseudopods present and they are attached at the edge, not detached, and typically present circumferentially. This finding helps us differentiate congenital melanocytic nevi and acquired melanocytic nevi with a globular pattern from the most common pattern seen in Spitz nevi, the starburst pattern. Moving on to congenital melanocytic nevi with a reticular pattern, they have a predilection for other areas on the body, more likely to occur on the limbs. This is a 17-year-old with a congenital melanocytic nevus with a reticular pattern on the foot. Instead of nests of melanocytes, there's an increased number of melanocytes and melanin along the reedy ridges. The hypopigmented areas are the dermal papilla. That's what accounts for the creation of the pigment network in these reticular pattern congenital nevi. Here's another example of a reticular pattern congenital melanocytic nevus on the thigh of a 9-year-old. Here we can see that there is central hyperpigmentation as well as a thinning and lightening of the pigment network towards the edges. Even with the naked eye, we can appreciate that there's some perifollicular accentuation of the pigment, and under dermoscopy, it's easier to appreciate this finding. Overwhelmingly, most congenital melanocytic nevi with either a globular pattern, a reticular pattern, or an overlapping pattern with some homogeneity to the brown base can be monitored, not removed. And for more management recommendations, I encourage you to explore this article that came out in Pediatrics a few years ago, which has excellent tips and tricks on counseling patients and family members about congenital nevi. I have a few more cases to share with you. This is a child who was born at Maine Medical Center in the United States. His mother is originally from South Sudan. And the pediatricians called us and said, this child has many hyperpigmented macules and patches. They're larger than 5 millimeters and bilateral. Do you think that these are congenital melanocytic nevi or cafe au lait macules? And the important differentiation there was if this child had multiple congenital melanocytic nevi, we would recommend an MRI compared to if these were all cafe au lait macules, the recommendation would be for testing for neurofibromatosis or Legius syndrome. This is what we saw when we looked under dermoscopy. Very, very well demarcated border and a uniform distribution of pigmentation. There is no presence of a pigment globule or a distribution of globules in aggregates or throughout. In addition, there's no patchy reticular nature to the edge, and the center is not hyperpigmented as we would expect in a child with phototype 5 or 6 skin. Instead, we see a homogeneous brown area all throughout with no accentuation around the follicles and a very crisp, distinct border. The other macules had a very similar appearance, a very stark, striking edge and uniform pigmentation with no perifollicular changes. Based on this, I said I believe these are indeed cafe au lait macules, not congenital melanocytic nevi, and I've recommended pursuing testing for neurofibromatosis, which was indeed positive. And here is the reference for those of you who are like me and forget all of the diagnostic criteria for NF1. This is the most up-to-date citation on that. One more case of neurofibromatosis, again in a phototype 4 child. She has multiple large bilateral cafe au lait macules, and under dermoscopy, that striking edge without any central hyperpigmentation and a uniform distribution of pigmentation all throughout the cafe au lait macule. One practical tip for differentiating cafe au lait macules from other pigmentation disorders is to just simply look at the cafe au lait macule and compare it to the adjacent skin. Cafe au lait macules have the dermoscopic appearance of a skin type one shade lighter than the patient's normal phototype. For instance, this child has a phototype 4 skin, which is normal seen on the right, and then the cafe au lait has the normal skin pattern that we would see in a phototype 5 patient, and then on the middle area, that is normal phototype 6 skin. So essentially, cafe au lait macules have uniform distribution of pigmentation, and that's what allows us to contrast them with pigmented growths, melanocytic growths like congenital melanocytic nevi. If a phototype 4, 5, or 6 patient did indeed have a congenital melanocytic nevus with a reticular pattern, we would expect there to be significant central hyperpigmentation like we see on the left from the arm of a phototype 4 patient. And instead, cafe au lait macules do not have that central hyperpigmentation. Instead, there's a uniform distribution of pigment. All right, next case was a telemedicine case that I received, and the pediatrician said this time, we thought this was a congenital nevus, but it's growing really fast. What is it? And it was not actually present at birth. When we used our dermoscopy, this is what we saw. Instead of globules all throughout, we see lacunae, lakes of blood, separated in a few areas by little white septae. This is an infantile hemangioma, not a congenital melanocytic nevus. With the naked eye evaluation alone, it was difficult to characterize this growth as a vascular neoplasm. But indeed, with dermoscopy, we can definitively say that this is vascular because of the presence of those lacunae. And while lacunae can be of similar size and shape to congenital melanocytic nevi that have globular pattern, the color is very different. In congenital melanocytic nevi, globules are brown, light or maybe dark brown, but in infantile hemangioma, those lakes of blood are typically red, purple, or sometimes blue. Dermoscopy can help play an important role in reducing diagnostic disparities. This article came out in the Journal of the American Academy of Dermatology last year and found that Black infants were presenting to care for infantile hemangiomas 4 to 6 to 8 weeks later than children of other races and ethnicities. It was theorized by the authors that this was due to difficulty recognizing these growths as vascular. And while sometimes with the naked eye alone, categorizing a growth as vascular might be challenging in phototype 4, 5, or 6 patients, Under dermoscopy, infantile hemangiomas present the same way in all skin types. We see lakes of blood separated by white septae in all phototypes. Sometimes we also see prominent white streaking. The prominent white streaking in an infantile hemangioma is a red flag that this is about to ulcerate. So not only does dermoscopy help us diagnose infantile hemangiomas and other vascular growths accurately, it can help expedite care for patients with high-risk vascular neoplasms like this one. If you would like more information on pediatric dermoscopy, I encourage you to look at these review articles on both vascular and melanocytic growths as well as skin infections in Pediatric Dermatology Journal. Thank you to Anthelios and the International Dermoscopy Society.